Uh, Hello, and welcome to the 2020 SNAP ENT National Forum session, SNAP ENT Pilots, Lessons Learned from Offering Innovative SNAP ENT Services Under Pilot Projects. It's quite a mouthful. My name is Rachel Gregg, and I am with the SNAP Office of Employment and Training at the Food and Nutrition Services, and I will be your moderator today. We have a pretty big panel, but they're all excellent speakers, and I'm excited to be a part of it. But I'm going to do a quick introduction of everybody, so it'll take us just a minute, but we're going to start with James Mabley. James is an Executive Director of Human Services at Mathematica. He is the Project Director of the SNAP ENT Pilots Evaluation and oversees the analysis of pilot impacts. We also have Gretchen Rowe. Gretchen is a Senior Researcher and Deputy Director for Nutrition Policy Research at Mathematica. She serves as a Principal Investigator for the SNAP ENT Pilots Evaluation and leads the implementation and participation components of the study. Felicia Talbot. Felicia is the Program Manager for the Washington State Department of Social and Human Services Basic Food Employment and Training Program, also known as BFET. Tracy Collier. Tracy was the Program Manager for Vermont's SNAP ENT Pilot. As the pilot wound down, Tracy helped expand the state's regular SNAP ENT program, the Individual Career Advancement Network, or ICANN. Mark Adams, also from Vermont. Mark is the Director of Research and Innovative Programs for the State of Vermont's Vocational Rehabilitation Department's INVEST EAP program. Mark helped implement and run Vermont's SNAP ENT pilot in collaboration with the Department of Children and Families, Economic Services SNAP ENT program staff. Like Tracy, Mark also helped transition the pilot into the state's existing SNAP ENT program, ICANN. And our last speaker from Vermont is Haley Turner Lawyer. Haley has worked for the state of Vermont for 8 years, for the past 4 years as part of the Vermont SNAP program team. Haley is the Vermont ENT program state lead, in addition to her many other responsibilities with Vermont's SNAP program. From Kentucky, we have Todd Trapp. Todd has 30 years of experience working for the Kentucky Department for Community-Based Services. He began his career with DCBS as a DCBS food stamp and AFDC eligibility worker, and is currently the Assistant Director of the Division of Family Support, which is the state agency responsible for administering the SNAP program in Kentucky. I hope I got everybody. I think I got everybody. Before I turn this over, I want to take just a minute to provide a little context about today's presentation. The SNAP ENT pilots were a huge undertaking for FNS and for the states and for our evaluator. They were part of the 2014 Farm Bill and really represented significantly increased interest in SNAP ENT from Congress, and a real effort to try and understand how we can make SNAP ENT services really more effective and to help SNAP participants move forward to towards self-sufficiency. That's really the goal. The way that FNS thinks about SNAP ENT now is it's really about helping to move families forward and to move individuals towards self-sufficiency. And the pilots were really an effort to try and understand what are the most effective services, what are the best ways we can build SNAP ENT programs to really help SNAP participants. It was a heavy lift from the beginning. I just want to really acknowledge that the states that participated in these pilots really did extraordinary work trying to get in some cases, SNAP ENT programs up and running from almost nothing. In other cases, they were able to utilize some of their existing infrastructure, but every state that was part of this pilot just did absolute yeoman's work to get this up and running. The evaluators have been with us every step of the way. From just me personally, I will say I really appreciate the patience that James and Gretchen have shown for all of our questions, all of my questions, and all of the things that we have asked them to do. This is one of the first presentations I believe that we have done about the pilot, so I'm excited to hear what the panelists have to say. Before we can get into that, I need to just do a little bit of housekeeping. So one, please remember that any discussions today do not reflect official USDA policy guidance. If you have a policy question, talk to your regional office and we will try and help get you an answer. And as you view the presentations, please ask your questions through the Q&A feature on the Zoom taskbar and add your comments in the chat box below. At the conclusion of the presentation, the presenters will have the opportunity to address your questions. So I just want to thank everybody for joining today's session, and I really want to thank our presenters, both for doing this session, but also for being a part of the pilots. I think that's everything that I have to tell you, so I will go ahead and hand this over to James.
Thanks, Rachel. Good afternoon, everyone. Thank you for attending this session. We've really enjoyed working on the SNAP ENT pilots evaluation for over 5 years now. We're excited to tell you more about the pilots and share some lessons learned from their implementation. Despite the importance of SNAP ENT, there's really limited information about which approaches are effective in connecting SNAP participants to employment. As part of the 2014 Agricultural Act, Congress authorized and funded 10 pilots to test an enhanced set of services in the SNAP ENT program, and funded a longitudinal evaluation of the effectiveness of these services in increasing employment and earnings and decreasing the need for public assistance benefits. In 2015, FNS awarded grants to 10 states shown on this map. The pilots covered diverse service areas, and some pilots differed in the populations they served. The pilots also varied in the enhanced services they offered, as Gretchen will describe in more detail in a minute. Each pilot enrolled 3,000 to 7,000 individuals for a total of over 44,000 individuals across the 10 pilots. Enrollment started between January and April 2016, depending on the pilot, and each grantee provided services for up to 3 years. The evaluation was a randomized control trial in which individuals were randomly assigned to a treatment group or a control group. Random assignment allows the evaluation to confidently attribute differences in outcomes between these groups to the enhanced set of SNAP ENT services rather than to other potential causes. There are 4 evaluation objectives. The first is an implementation analysis. The goal here was to understand the context of each pilot and its operations. If FNS or states are thinking about replicating certain programs or offering specific sets of services, what lessons did we learn from the pilots? Understanding implementation accomplishments and related challenges also helps us to interpret and understand some of the impact findings. And the data here consists mostly of discussions with grantees, partners, and provider staff, and focus groups with participants and employers. There is a participation analysis as well. It's the second evaluation objective. What services did treatment group members receive? How did they differ from control group members? We also examine how long treatment group members spent in the pilot and whether and why they exited the pilot. These data consist of administrative service use data that track individuals' receipt of services in each of the pilots, and each grantee had their own system or a set of systems from which we obtained this data. And we also administered a 12-month survey to individuals who were randomly assigned to obtain more information about service receipt. The third objective was an impact analysis. What is the effect of the enhanced services on individuals' outcomes like employment, earnings, and SNAP participation? The main data sources were the baseline data collected consistently by caseworkers at the time of enrollment and provider staff. UI wage records and our 12 and 36-month surveys provide information about earnings and employment. And the surveys also provide information about outcomes such as food security, housing, health, and depression. And SNAP administrative data, which provide information about participation in SNAP, TANF, and Medicaid. And the fourth evaluation objective was to perform a benefit cost analysis that describes the total and component costs of each pilot and how these costs compare to the benefits based on the impact findings. These use cost data we collected from providers as well as staff time use surveys. Here's an overview of the pilot and the evaluation timeline for the past few years. Most of 2015 was spent planning for the evaluation and the start of the pilots. We provided guidance and technical assistance to pilots through conference calls and webinars and in-person meetings with grantee staff. The focus was really on planning what outreach, recruitment, and enrollment would look like and discussing service provision and partnerships. And the goal here was to help grantees think through these plans as they related to ensuring the integrity of the evaluation. To that end, we also trained grantees on pilot-specific study intake procedures, including explaining informed consent to individuals and registering them in our enrollment system, and then eventually conducting random assignment. In 2016, in early 2016, between January and April of 2016, all the pilots started enrollment and became operational. We designed a baseline registration system for grantees to use to enroll individuals in the pilot and obtained the required baseline data and conducted the random assignment. We also provided technical assistance and monitoring in terms of recruiting, enrollment, and service provision, overseeing all of those in this period. This continued into 2017 and 2018. We launched our 12-month primary data collection effort in January 2017, and that lasted for 2 years. And many grantees in 2019 and 2020, many grantees had reached the end of the service period at the end of 2018, and so in early 2019, and we worked with them through that process. And between January 2019 and now, we've been working mostly with data, performed a lot of estimation work, and wrote 10 interim reports, one for each of the pilots, and a summary report looking across pilots that are currently being reviewed by FNS. So looking ahead from now through late 2021, we're continuing to collect a lot of data, especially administrative information on UI and SNAP, and we're administering our 36-month follow-up survey. This information will allow us to measure longer-term impacts of the pilots on outcomes, which will culminate in a set of 10 evaluation reports in 2021, early 2022. Thanks. Gretchen?
Thanks, James. So before we hear more about the specific pilots from the staff who administered them, I want to provide a high-level overview of what all the pilots looked like. So all of the pilot grants were awarded to the SNAP agencies in each state, but they all had providers they all partnered with service providers who provided direct services to individuals who were in the pilot. And some of the grantees also partnered with non-provider organizations that helped with aspects of developing the pilots, overseeing the pilots, or helping with administering them in some way. Service providers were typically workforce agencies, education or training providers in the community, or community colleges. The non-service or the non-provider partners were generally some type of CBO, workforce boards, or other councils or boards in the community. The pilots generally offered the same type of program as what the state was operating in the pilot areas. And at the time of the pilots, most of the states were operating voluntary programs. 3 of the 10 were operating mandatory programs in at least some of the pilot areas, and they were Georgia, Illinois, and Mississippi. So 2 of the pilots were operating statewide, including Vermont, who's here today. States that did not offer services statewide generally targeted regions that were most in need of services, had large target populations, or had providers who could readily offer the enhanced services that were needed. The areas served ranged from 1 county in California to 35 counties in Kansas. Most of the pilots were serving a mix of urban and rural areas, but pilots in Kentucky and Vermont targeted primarily rural areas. And all of the pilots were serving work registrants or targeting them for the pilot, but about half were focused on a subset of this population. For example, Georgia and Mississippi targeted able-bodied adults without dependents or ABODs. And Vermont and Washington targeted individuals who had significant barriers to employment, such as those with substance use disorders, mental health disorders, a criminal history, or people who had unstable housing. And I'm sure we'll hear more about that today. Sorry. There was no single service model that states developed for the pilots. There were essentially 10 different models. States were not required to incorporate specific services or activities into their models. However, as mentioned, Congress and FNS wanted to fund and evaluate innovative strategies. So those that really offered things beyond job search or job placement activities. All of the pilots did this, but they did it in different ways. So some pilot models featured tracks where individuals entered based on certain interests or requirements. For example, Delaware offered 3 industry-specific tasks or focus tracks, whereas Virginia offered a set of services through 3 tracks that were based on individuals' reading level, so they tested into a track. Some pilots required individuals to complete a set of activities or services up front before engaging in other activities. For example, Mississippi and Washington required upfront soft skills or life skills courses that took place over several weeks before individuals could move into training or employment activities. Vermont and Washington also focused on reducing barriers before individuals were referred to substantive activities. This could take several weeks or months depending on people's barriers. So the other pilots were less structured and offered an array of activities, such as job readiness training, basic education, occupational skills training, or work-based learning opportunities, which are things like subsidized employment, work experience, and work study. And they offered these as a package together based on each individual's needs and interests. So there was a lot of flexibility of what an individual would receive. Most of the pilots included more intensive services like case management and support services than what was offered under the existing SNAP E&T programs. Pilots generally included what was referred to as intensive case management, but these definitions varied. Some pilots would require weekly check-ins with individuals, others required monthly check-ins. In addition, the models that were used for providing case management varied quite a bit. Many pilots generally used the procedures that the providers would use with anyone who came in to receive services. However, some grantees revised the intake process to focus more heavily on assessing barriers and implementing strategies to mitigate them. Others also hired or trained specialized staff to provide clinical social worker counseling or trained staff to use coaching or mentoring approaches for case management. And some of the pilots had individuals who were accessing services at multiple organizations, and a few pilots used a team-based approach to coordinate case management across the providers. And then finally, with regard to support services, well, standard or existing SNAP E&T programs all provide support services or what's called participant reimbursements. The pilots usually offered higher amounts of those supports and offered a wider array of them, including things like housing, personal care, which is things like dental work and eyeglasses, or training and work supplies. So now we'll hear from staff in Kentucky, Vermont, and Washington who will discuss their pilots and the lessons that they've learned. Oops, sorry, Todd.
Hello, I'm Todd Trapp. I'm Assistant Director of the Division of Family Support in Kentucky. The Division of Family Support is the state agency in Kentucky that's responsible for administering the SNAP program that includes the SNAP Employment and Training Program. Our pilot in Kentucky was named Paths to Promise. And so Paths to Promise, that pilot application was the result of a collaborative effort of the partner agencies. And so really it was designed to use a collective impact approach to align services from those agencies, I should say employment and training services and programs from those agencies, to improve delivery to SNAP work registrants in the Kentucky Promise Zone counties. Next slide, please. And here are those partner agencies. We have the Department for Community-Based Services, which is the department my division is in, the Kentucky Department of Workforce Investment, and then the Eastern Kentucky Concentrated Employment Program. That is the agency that is one of Kentucky's 10 local workforce development areas. And they operate Kentucky Career Centers in each of the Promise Zone counties. And then Kentucky Adult Education, the Kentucky Community and Technical College System, KCTCS, they have 16 colleges across the state. 3 of those are actually in the Promise Zone area, so that they were a big resource for the pilot. And then Jobs for the Future is our only non-service providing partner. They were instrumental in helping us implement the collective service model. Collective impact model, I'm sorry. Next slide, please. This diagram here illustrates that collective impact approach where the partner agencies all leverage resources and services from one another through a team-based case management model, all focused on the shared pilot goal of increased earnings and employment for SNAP work registrants in the Promise Zone. Next slide, please. The pilot location, as I just mentioned, is the Kentucky Promise Zone. This map here illustrates where those counties are in the state of Kentucky, and that is actually in the heart of Appalachia there, those 8 counties. And those are all considered distressed counties, high unemployment, low per capita income, high poverty. They're all actually, at the time of the grant application, those all ranked in the highest 10 you don't want to be in poverty nationally. The economy of those counties is historically driven by the mining industry, which of course has taken its hits over the last 8 or 10 years. And that has led to an increased unemployment there. And a lot of the employment challenges there are the deficit in post-secondary education, limited public transportation. We see that across the state, really, outside of about 3 or 4 urban areas. But the mountains there make it even more serious a problem. And then long-term unemployed and just a general lack of work experience. So as I said, the target population we chose was really just the SNAP work registrants in those 8 counties. At the time of the application, there were about 18,000 work registrants there. So we thought that would be plenty. However, with the targeted enrollment goals for the control group and the treatment group, that wound up being a tall order, even at that number for 8 counties. So next slide, please. The pilot services included coordinated case management and opportunity for supportive services. And that would be, as Gretchen said earlier, we encouraged the partner agencies to kind of stick with what they knew, but in addition to that, layer on some team-based case management. In other words, working with the other partner agencies to reinforce and make referrals for other services. And so along with those services from those other agencies or from that group of partner agencies, there would be educational and career assessments, education training opportunities, obviously through the community college system and through the Kentucky Career Centers. We offered some tuition assistance for educational programs 2 years or less that would meet the ENT requirements. And then some work-based learnings, which could include a subsidized wage, work experience, on-the-job training, internships, and paid work study positions. Success coaching through the partner agencies. And then another aspect of our application was an employer resource network. That came in through workforce investment, and the Career Center had that idea, and we added that to the pilot. And it was a challenge to get that implemented. Took a little bit longer really to get that rolling than we had initially planned. And it worked. It worked in the areas where they were able to implement it, but it just wasn't a good match for SNAP ENT, I don't think, because of the funding aspect of it. In addition to those pilot services, we also offered supportive services. And we set these supportive services up along with sort of the case management model from DCBS. Our idea was to pattern some of these things off our Kentucky Works program, which is our TANF employment and training program, TANF funded employment training program that we've operated since welfare reform. And so we offer very similar supportive services to these for transportation, help with childcare assistance, And then we partner with agencies to make mental health referrals, substance abuse assessments, and things like that. And then also we offer cash assistance for vehicle repairs. Those are vendor payments. And then to help with other things like dentures, work, tools that individuals need for work, or uniforms and things like that. And so those have been successful for us with the Kentucky Works program. And so we wanted to use them here as well. And the 100% funding gave us an opportunity to do that. Something we can't afford. Those kind of services are something we can't afford with the 50-50 match without a general fund allocation. Next slide, please. Some of the challenges we faced were implementation. It was across this number of partners. The policy alignment piece was, as I said, we asked them all to work within the programs they were already offering, but we had to meet some of the SNAP rules, and that's where it became a challenge. And so eventually we got a provider handbook out, and we were able to meet those challenges. And then these agencies haven't been, these agencies, the Career Center staff really is what I should say, weren't used to dealing with this kind of population, this recipient population that kind of needs a little more hand-holding. And so the professional development and training, that's kind of what that's aimed at, is really that case management training that you need to build that rapport and develop those relationships to get the trust you need to help identify the challenges people are facing and meet those challenges. And then recruitment limitations, that kind of ties into that as well. Being able to reach out to those folks and build that trust, get them to agree to do the assessment that was required and make the commitment that was required to enter into the program. The data management system, I think that was mentioned by James earlier. That was a little bit of a challenge. It just kind of added another layer there of another system for this group of staff to learn and to work in. The evaluation, I'll say in itself was a challenge. And absolutely, we're looking forward to the reports that come up from that. But the evaluation itself was just added to another challenge to implementing the program, or the pilot, I should say. Collective impact, I think that was, very valuable for the pilot, but it was getting the workforce partners, the post-secondary partners, and the human services organization partners to agree on goals and objectives. That was a challenge in itself, but eventually we all got there, and at the end, I think everybody appreciated the program. The employer resource network, I should say, was, as I said, a challenge to get going. It just because of the funding aspect and the fact that once you're there in that employer, you could only serve SNAP recipients. That is what really created a challenge there, because the idea of the employer resource network is employers start to buy in on it. We funded that with some grant money to get it going, but then it could only benefit grant treatment group recipients. And so it was just a very big challenge. Next slide, please. I think, and this staff in the field would agree, that the team-based case management model worked very well. And it was very effective in getting all the partner agencies into basically that cross collaboration between those agencies on dealing with a client. If you had a participant who could benefit from referral to another agency during these team-based case management meetings, which would happen either every 2 weeks or maybe once a month, they would have a chance to talk about those things. And sort of help keep those clients from triangulating and just keep everybody focused. It was very successful. The supportive services, I think, that's one of the things we heard from staff and participants is the assistance with transportation was one of the biggest things, one of the most helpful things in increasing participation. Recruiting and referral, I think we struggled with recruiting and referral to start with. And DCBS eligibility staff weren't a big part of the recruitment effort to begin with. But about midway through the pilot, they developed an electronic referral tool, and that really helped. And then video success stories. EK Sub developed some participant videos, and they were a really good helpful recruiting tool. They were very effective at letting those participants see how the program had helped, these individuals in the videos. And then also we began to do recruitment efforts at local DCBS offices, and just the knowledge and the understanding of those eligibility staff who had worked with this population really helped there in the sort of the second half of the operation of the pilot. We were able to pull them in, really increase that recruitment effort at the end. Next slide, please. So I think as we look at what worked, not having seen the real outcomes from the grant yet, as we looked at that and as we looked at our current ENT program, we were not operating ENT in any of those counties when this program began. In fact, we were only operating it in, I think, 8 counties statewide. And we were really beginning to push to grow and to establish partnerships. And absolutely the partnerships that we implemented through the pilot showed us the value of those partnerships. And it's through those partnerships that we were able to really learn the value of team-based case management and of leveraging resources from each of those different partner organizations. So those are 2 big things that we have taken away and are using. Team-based case management, we don't use everywhere that we have operating ENT now because we just don't have that wide a group of partners in every location. We absolutely encourage it whenever possible and when those opportunities present themselves. And then the other thing is supportive services. And as I said, we've known for a long time the value of those kind of things, those kind of services, those the transportation, the help with the different things, and what value that's added to our TANF program. We would like to provide the same thing, but we simply do not have the funding to provide that level of transportation assistance or those other supportive services. That's something that 100% funding was very helpful. So those are pretty much our lessons learned. So I'll give it back to Gretchen now. Thank you.
Thanks, Todd. Tracy, Mark, Haley.
Thanks, Gretchen. My name's Tracy Collier, and I served as the program manager over the 3 years of the pilot. I am excited to have the opportunity to share the Vermont experience with you today. Our Vermont pilot, as Gretchen said, was statewide, and we called it Jobs for Independence. We had an amazing group of individuals and agencies, both leadership and direct service providers, committed to morph our existing services and expertise into a program that could meet individuals where they were at and focus on barrier reduction across the agencies and use regional teaming that will allow individuals to reach their employment goals. We focused on folks who were in the high barrier group, including homeless or at risk of homelessness, who had addiction issues or mental health issues, or involved in our correctional system. They self-identified to be eligible. They also needed to be active on Vermont's SNAP program that we call 3 Squares Vermont, and not active in any of our TANF programs that we refer to as Reach Up. Our pilot set a goal to enroll 3,000 individuals. 1,500 of them would be assigned to the treatment group, and 1,500 of them would be assigned to the control group. The system of delivery involved a multi-agency approach that focused on addressing immediate needs and moving individuals to the next step of the program. To illustrate that, I'd like to share a story about Sonia. Sonia, who was age 50, found her way to the local community action agency. She was seeking help because she was homeless due to fleeing a long-term abusive relationship. Community Action found out that Sonia was on active 3 Squares and not active on Reach Up. They shared with Sonia that she was eligible for a new program in Vermont called Jobs for Independence. Sonia agreed to attend the orientation at Vermont Department of Labor. Once she heard about the opportunities that Jobs for Independence could provide for her, she agreed to participate and was randomly assigned to the treatment group. The EAP counselor soon discovered that Sonia had multiple medical issues, including back pain and carpal tunnel, that would require surgery. Her multiple barriers to employment were addressed through her work with the regional team, including local women's shelter. After several months of intensive services, including emergency housing through the shelter, Sonia was able to get a job in a local clinic providing front office support. The job was successful, leading to permanent housing and having her JFI case closed. Next slide, please. As folks went from the Community Action Agency to the Vermont Department of Labor and then referred to the EAP for treatment services, we monitored closely the drop-off rates through the pilot. We were very pleased that 83% of folks showed for the first appointment, and we credit this to the great percentage with the teaming of the direct service providers. Common messaging from the start of the process led to individuals understanding each step of the process and getting excited about the opportunities. Mark's going to share with you more about the VR EAP experience.
Thanks, Tracy. I too am glad to be able to talk with you about our pilot. And as a trained clinician, I'll apologize ahead of time. I'm better at listening than talking, so my apologies for if I flub up. In terms of that flow chart, back one slide, if you could, Gretchen. Folks would come in through our system of community action into the Department of Labor and then referred into EAP. And then that was sort of the teaming, the beginning of the teaming. We also had our Community College of Vermont providing the Governor's Career Readiness Certificate that was both a soft skills and some literacy and computer skills based support to get them to sort of a baseline level of employability with those skills. Next slide, Gretchen. In terms of the appointment with EAP at first, when the treatment group had their first next step appointment with EAP, they did receive an incentive, and I think that helped keep that high rate of attendance, that first appointment. The goal that EAP had was to create an environment where folks that had been disenfranchised for very long periods of time could come in to a new kind of new experience of joining with a partner and basically being allowed to sort of share their story, share their goals, and basically build their plan with an EAP counselor that would support them and act as a cheerleader, act as a coach, act as a counselor, but mostly act as a partner. We used a lot of motivational interviewing tools, active listening, change agent processes. Those were the ways we can engage those folks and basically show them over time that we were going to be with them when things were good and when things were bad. So as we did that first appointment or two, we would do a barriers assessment and a psychosocial for them. That helped us to provide a frame to do the referrals and build the team. As we built the team, we tried to do as many of these as warm handoffs, where if someone was in a housing crisis, the EAP staff and potentially maybe an employment consultant from Weber would meet with a housing service provider and the participant and introduce them. And some of the relational bandwidth that was created for that partnership that had been happening with EAP could be transferred to that next step. And it was a little less frightening to go into that for the participants, because they were able to know that they were in a team and that people were going to support them as best they could. But that was the main focus of us building teams around these folks. Next slide. The other component of that was super helpful, that I think Todd has talked about as well, is the ability to support folks in a somewhat long process of getting them ready to be employed. The targeted support services that we had in Vermont helped with housing, transportation, some of the supports around fidelity bonding. We also have a program called CRASH in the state of Vermont, which is this program that supports folks who have had multiple DUIs and have lost their license regain their license with a professional alcohol counselor. So we were able to even pay for that to get people's license backs. One of the stories that we have that illustrates this really well is that we had a gentleman, Jim, who was placed in the treatment group for the pilot. At the time of his enrollment, he was struggling to find employment as he was on the sex offender registry. The impact of this was that he wasn't able to afford his housing that had been set up by the Department of Corrections. And if he lost his housing, unfortunately, he would go back to jail. Through the JFI team, he was connected to housing resources, and through these funds, we're able to support Jim in securing his apartment so he did not return to jail. The team then connected him to a local therapist to do additional treatment work around his sex offending, as he was also doing the mandated corrections group sex offending treatment. During this process of all that treatment and supporting his housing, he applied for over 100 jobs until at one point he was able to land a job, a part-time job in a cleaning crew. When he landed the part-time job, his benefits still stayed, even though it was reduced. We were able to support him in getting to the community action program to set up some financial literacy goals for him. And he was able to set up a savings plan and a credit development process where he was allowed to save up some funding and was able to get a car. He was able to then get to work on a more regular basis without help from the program, as well as from his supervisor, who was driving to work periodically. He then became a full-time employee at this cleaning crew and was off the benefit. He did return 6 months later and advised that he had become full-time as a supervisor and was hoping that we could submit other folks that were on the JFI pilot for him to potentially employ. So that's an example of how all these services, the teaming, the support services, and the efforts by the participants can really focus and over a long period of time can really develop some self-sufficiency. Next slide, Gretchen. So we did lots and lots of work around reducing barriers. And that put people in a position then to focus on their work and their work training. And it was in these teams that we developed regional groups that met. Some met weekly, some met bi-weekly, and some met monthly to basically do case discussion, system improvement, troubleshoot cases that were potentially falling off, or a participant that was lost to one of the providers to regain that connection back. And that was the goal of the teams, was to really integrate, similar, I think, to how Kentucky had talked a little bit about the way that a team could wrap around an individual and help them have a safe harbor, that even if they went out and had some troubles, maybe they got a part-time job and that didn't work, they could come back and be supported by the team as long as they stayed eligible for the 3 Squares benefit. I think Tracy's going to talk about the next slide.
Thanks, Mark. So Mathematica and FNS visited Vermont several times over the course of the pilot, and they shared with us some things we'd actually already knew. One of the things was that we the providers, the direct service providers for Jobs for Independence really appreciated the ability to team around the client needs and share that cross-agency approach. As they move people, they felt like they were moving them a little further than they might have been able to on their own, or a little faster than they might have been able to on their own. And I think we didn't hear this from them, but I think the clients also felt the momentum of that wraparound approach. That our drop-off rates were really good. We didn't lose people between the different provider agencies like we thought we might. The people that went to Community Action actually showed up at Department of Labor, and the people who got to Department of Labor and were referred to EAP services made it to those EAP services in a high percentage of cases. So that was a good thing that worked out for us. We believe that was due to the communication that started at the Community Action Agency and followed folks throughout that process. The communication between providers, folks were really appreciative of the fact that we had multiple places where we could communicate about the program and how things were going, and we could pivot accordingly. So we had monthly leadership meetings. We had statewide calls regularly. We had the regional teams meeting separately, where we had leadership joining in as much as we could. And we had statewide conferences throughout the time to keep learning together and providing that service. So those were some really positive things that happened. Some of our challenges, though, were that we had an influx of people that we couldn't really anticipate for in some of our larger service areas, and staffing levels were not at the point where we could meet all the needs in a timely manner. So we would have wished for more staffing, and we had to pivot and move staff a little bit to address that, but we did do that. All the programs have their own data systems, and Mathematica had a random assignment system that we needed to implement, and Economic Services Division also stood up a new system. So folks were entering into their own systems. They were using the random assignment system, and they were also using the new Economic Services system to provide data points along the way. And that's challenging, but we did make it happen. But that is a troubled place. Another challenge was supporting participants with transportation and housing. In Vermont, our rural nature is such that transportation, even though we addressed a lot of transportation needs along the way, that it was challenging. It still remained a challenge. Also housing, even though we were able to provide emergency housing supports, we just don't have enough housing stock. And so that was important. That was just one of our challenges, and it remains a challenge for us. I think Haley's going to talk about where we are now.
Yeah, hi. Thank you, Mark and Tracy. In terms of our program, Mark and Tracy were working within JFI, and I actually was not a part of JFI and that pilot program. I came in and was working with the ENT program that Vermont had, and as JFI was wrapping up, Tracy and Mark we all joined into one team to see how best practices and lessons learned from the pilot could possibly be included into our SNAP ENT program. And through that, we actually created the Individual Career Advancement Network, or ICANN, which is the name for Vermont's SNAP ENT program. The goals of the basically transition was to maintain regional employment teams and community-based service teams, as well as continuing to refer high barrier participants to VREAP to assess and support barrier reduction, and also to promote participant voice and self-determination. One of the goals was also to continue the partnership that had been built through JFI with partners within the employment realm. Next slide, please. So with Vermont, we envisioned a SNAP ENT program through our employment network where Vermonters with low income have clear pathways to overcome barriers and develop marketable and in-demand skills, leading to career advancement. So with the creation of ICANN, we were enrolling individuals, and I do have a success story here. We had a participant who came into the program in her late 30s with addiction as well as some psychosocial issues. And she had a very, very complicated post-traumatic stress disorder due to homelessness, and kind of being at that point of where she was just doing everything in her power to survive. By getting connected to ICANN and the network, they were able to slowly work with her and establish local support such as a physician, a female counselor, and then also being able to help her look at that comprehensive employment plan in order to move her forward. So after multiple months of support in order to get that ICANN team as well as the larger team together, she was actually able to complete a college-based credential that provided a direct pathway to professional customer service. Currently, she is employed and looks and like a completely different person than she had when she first began ICANN. And we really do credit that to her own hard work as well as the team that was built around her, and just the positive regard that the ICANN team was able to provide to her as she entered the program. Next slide, please. Now, kind of looking at where ICANN is today, it has been a couple of years since we've shifted our program. And as of 2020, I believe these numbers are from the end of September, we had enrolled 870 individuals. And this is actually an increase of about 200 individuals from 2019. We do have a really big focus on case management within our program, which is focused on reducing barriers, meeting participants where they are at, and ensuring that participants continue to have a voice in the process. With 2021 starting, we are continuing to strengthen our partnerships and build on the strengths of those partnerships. So in 2021, we're transitioning to a model where VREAP as well as the Vermont Department of Labor will provide case management to better support participants where they are at. And then Economic Services, which is our SNAP employment, our SNAP administration agency, we are now providing orientation and other supports as part of that teaming model. I think Gretchen?
Great, thanks everyone. So Felicia, do you want to talk about Washington?
Hi, I'm Felicia Talbot, and I am with Washington SNAP ENT program, BFET. I've been with BFET about 8 years, though I had the opportunity to work on our RISE pilot for about 2.5 years. So I'm happy to be here to share about RISE. When Washington began thinking about a pilot and developing ideas around the pilot, we looked at our current SNAP ENT Basic Food Employment Training, BFET. And what we found was that about 70% of our BFET participants were successfully completing the program. And so we took a look, we looked at what was happening to that other 30% of the BFET population who weren't able to complete their BFET program. And so, next slide, please. From that kind of assessment and thinking about a pilot, our pilot was RISE, Resources to Initiate Successful Employment. And so our goal in RISE was to fill that gap, to work with that, to focus on that 30% of those BFET participants. They generally were facing multiple barriers to a path to employment and lacked needed work experience to gain employment and retain it. Next slide. So our focus in the RISE pilot included 3 elements. And in the RISE pathway, the first was comprehensive case management and really working with those participants that had several barriers. It was a standardized approach. RISE case managers were required, it was a program requirement that they meet with the RISE participants once a week and work with them on reducing barriers before even moving to the first training. And that second, or the first training opportunity would be a soft skills training called Strategies for Success. And that was a required training that included 96 hours of soft skills trainings over 6 weeks. Once participants had completed Strategies for Success, they were able to, depending on their employment goals and their pathway, they may have entered employment training activities and or including work-based learning activities. So the RISE goal for the pilot was to enroll 5,088 participants in 4 specific counties. And in those counties, we contracted with community-based organizations, mostly nonprofits, and 2-year state colleges that actually delivered the RISE services. And in those counties, we also contracted with Washington's Employment Security Department, and they delivered the Strategies for Success, that soft skills training to participants. And finally, we contracted and worked with the workforce development councils in those 4 counties to provide the navigation in work-based learning to connect those RISE participants to industry tours, work experience, job shadowing, and other related work-based learning opportunities. So Washington implemented their RISE pilot with a soft rollout December 1st of 2015 through January 31st, 2016. So that was about 2 months. During that time, all RISE eligible clients were enrolled and began receiving RISE services. During that time, we were also able to utilize an automated eligibility screening that was already up and running in our existing electronic jobs automation system, EJAS, and that's where a lot of our division programs lived. Our full rollout implementing RISE with the randomization into the treatment and control groups began February 1st, 2016. And we initially began only enrolling work registrants into the RISE pilot, though eventually enrolling non-work registrants up to that 15% that was allowed in the pilot. With the start of the pilot, all RISE components for the RISE pathway were available, that comprehensive case management from day 1, Strategies for Success training, and then the ENT activities, job training, under education, also education, and then work-based learning. So some of the challenges that we faced in the pilot, technology implementation. So we did have an existing EJAS system that we did add a RISE model to for all of the case information and activities. And that RISE model, while it was added to our existing system, we found that there were lengthier times to adapt that system to the needs of the RISE case management and the items that we were tracking. We also faced a challenge with some of our providers not quite understanding the definition of work registrants. And so we spent some time working with our providers and providing support and education and information about who we were looking for to enroll in the pilot. Another challenge that we faced was the release of SNAP applicant contact information. We thought this would be crucial to the 4 counties, be able to provide those providers with SNAP applicant contact information And we eventually achieved this, though what we found was internally, our internal state processes, again, were lengthier in time than we anticipated. We began the RISE pilot with about 3 FTEs in the program area, and we found immediately as the pilot started that it would be crucial to have program consultants in each of the 4 counties. And so we worked with that challenge and eventually were able to provide more staffing and provide a consultant to support the program and manage the program in each county. And finally, a challenge that was really between Mathematica and Washington's Employment Security Department in terms of a data share agreement. And Washington's ESD department was bound by some National Department of Labor guidance and requirements that it just turned out to be a long drawn out process, though eventually achieving a data share agreement. So what works well in the RISE pilot from day one, from the planning of it all the way through the end of the pilot, was that our partnerships with the workforce development agencies, with other state agencies, our state board colleges, our BFET providers, everyone was involved from day one of planning and implementing the RISE pilot. And their feedback at the beginning and throughout the whole pilot was valuable. And it solidified our partnerships moving forward. And also, our existing BFET program was strengthened because RISE providers transitioned to become BFET providers if they weren't already at the end of the pilot. So our overall SNAP ENT program was strengthened through as a result of this pilot. Some of the things that we worked on throughout the pilot, we provided ongoing training with all of our providers in the 4 counties, and that included technical support with our EJAS system. And we held monthly county meetings and quarterly statewide meetings with all 4 counties in attendance. And those proved to be valuable for the providers and for our team managing the program. Into the first year, we realized that we were looking at the definition of long-term unemployed and found that we may have been missing some potential participants that were eligible for the pilot. And so we worked with FNS on expanding our definition of long-term unemployed. And it was in a rural area that was affected by seasonal and day labor, but also seasonal employment. We also implemented some support service changes as the pilot went on. We recognized, and of course, feedback from our providers helped us to improve policy changes that would have a positive effect for clients. And of course, as I mentioned, we worked with our existing EJAS system to add the RISE model for all of the case management documentation and tracking. We also had something, we had developed a database called the RISE Suite, and that's where work-based learning opportunities, those employer connections, our navigators and work-based learning provided that information in this database, and also the strategies for success, that soft skills training schedules, were all in one place for providers to access. And as the pilot was, throughout the pilot and as it came to an end, we were looking to the future of our existing SNAP ENT, our BFET program, and case management, also making strategies for success, that soft skills training, available for BFET participants that were not pilot BFET participants that were under the embargo. And of course, we look forward to eventually including work-based learning in our program. And we continuously look at our support services, those participant reimbursements for our BFET program, in ways we can improve. And on a final note, last slide, please. What in RISE would we have? What would we like for our BFET program? And as I mentioned, work-based learning, we are definitely looking forward to eventually, when we have guidance and have the ability to add work-based learning to our BFET program. And specifically, there were a couple support services, participant reimbursements in RISE that we would like to hopefully someday be able to approve in our BFET program, and that is around car insurance and cell phones. So thank you for the opportunity to share information about the RISE pilot in Washington.
Thanks, Felicia. Sorry. Here we go. So I was going to talk a little bit about some of the lessons from across the 10 pilots, but I honestly think a lot of what has come up from the 3 pilots covers most of this content, and I know we're running a little low on time, so we'll include the slides for people to view, but I think that we've touched on this, the importance of partnering, which I think everyone talked about. Some of the issues with developing new systems and new services can be complex and challenging. Also, staff struggled with some of the recruiting, which I think Todd touched on a little bit, and also some of the take-up of services was different than what was anticipated initially. And finally, a couple of the other points were just that some of the service models sometimes affected the rates of service take-up, and people had to make adjustments kind of and be flexible about how they worked to ensure clients were moving through the system. And then also, again, I think everybody talked about the importance of support services being really key to getting individuals into activities, but also that everyone wasn't able to necessarily provide all the support services that were needed, particularly around transportation and housing. And I think Vermont touched on that really well. So, Rachel?
Yeah, so thank you, Gretchen, and thank you to all of our speakers. I really appreciate this presentation. I stood very close to the pilots and I watched everything that y'all did, and it's still very interesting to hear you talk about it. So we're going to go into a live Q&A section. Hopefully some of you have submitted questions in the chat box during the presentation, but if you didn't, there's still time. So if you'll just use the Q&A feature down at the bottom of the screen, we'll be able to go ahead and answer those questions. I want to take just 1 second and thank all of our presenters, as well as all of those of you who are participating in this presentation. And I look forward to the conversation around your questions. Thanks very much.